So my name is Dr. Siti Rohani. I'm a radiologist, now is Thoracic Radiology Fellow in HKL. So today I'm going to present about chest X-ray interpretation. So the lecture today will be in two parts. The first part I will be talking about radiologic manifestation of disease, basically focusing on consolidation and atelectasis. After that, I will be talking about cases, example of chest X-ray cases in emergency setting. I think this is the second or third time I have given this lecture CME to ED. So it a little bit different from the previous lectures. Okay, so we start first with consolidation. Consolidation on chest X-ray defined as a fairly homogeneous opacification associated with obscuration of the pulmonary vessels or little or no volume loss. So we know that consolidation on chest X-ray present as opacity, and it can obscure vessels and linings like heart, border, and the diaphragm. So the pattern and distribution of consolidation, presence of lymph nodes, clinical symptoms such as fever and hemoptysis, travel history, will give you the clue to the differential diagnosis. So what I'm trying to make the point is consolidation on chest X-ray is the definition is defined as opacity which obscure the pulmonary vessels and heart and diaphragmatic border. So what consolidation made of? It can be made of water. In case of pulmonary edema, it can be made of blood. In case of pulmonary hemorrhage, pus in pneumonia. Any consolidation can also make of cells in case of adenocarcinoma, lymphoma, even organizing pneumonia. The consolidative OP is consists of cells. Okay, fat in deployed pneumonia and protein, alveolar proteinosis. So there are a lot of things going on chest X-ray opacification, which is consolidation. So we couldn't tell which one is which, only based on one chest X-ray. Okay, that's why the other associations such as pattern and distribution, presence of lymph nodes, history, fever, and other travel history, these are very important for us to differentiate between this differential of the causes of consolidation. So in radiology findings, consolidation, as I said just now, is fairly homogeneous opacity associated with obscuration of the pulmonary vessels and little or no volume loss. Because consolidation is air-space opacification, so all the pus or fluid or cells is inside the airspace, so it doesn't cause volume loss. Okay, sometimes it can cause expansion, volume expansion. The margin is ill-defined except when it abuts the pleural or fissure, which it will give a very well-defined boundary. And the classic findings will be presence of air bronchogram. Air bronchogram in consolidation is caused by the airways, which is still aerated within the area of consolidation. Okay, we know the definition of consolidation is pathology in the airspace, not in the airway. That's why we can see air bronchogram in consolidation. Next is a silhouette sign. When you see consolidation, the visible mediastinal and diaphragmatic contour of the mediastinal structure is defined by interface between the air in the lungs and the structure itself. Okay. For example, in this left side, we can see a very nice line of left heart border. So that's a silhouette. When the silhouette is obscured, especially of the aorta, heart, or diaphragm, the obscuration can be because of pathology, for example, consolidation or mass. Okay. So the knowledge of the silhouette, of what lines, what makes the lines and borders is important for us to detect the abnormality of chest X-ray. But there is a pitfall on silhouette sign. In this case, in chest X-ray with underpenetration, the chest X-ray will be more opaque or white, so it is quite difficult for us to appreciate the silhouette sign. And in this case, a patient with pectus excavatum, we cannot see the right heart border clearly. This is not because there's a consolidation or mass at the middle lobe here, is because of the anatomy, the pectus, the pectus deformity of the chest wall that cause the heart to be slightly shifted to the left behind the sternum. So we cannot see the right heart border. So for consolidation can be focal or multifocal. It can be segmental, non-segmental, or it can involve the entire lobe of the lungs. And this pattern of distribution have different differential diagnosis. Segmental consolidation, we might be thinking of endobronchial obstruction, or pulmonary infarction, aspiration, or pneumonia, or other infections such as more severe fungal infection in immunocompromised patient. In non-segmental or in lobar consolidation, we will be thinking of strep pneumonia or Klebsiella pneumonia, which cause increase in lung volume and lobar expansion rather than slight volume loss, and bulging of the fissure sign, as well as bronchial obstruction. So this is a type of lobar pneumonia which involve the almost the entire of the upper lobes. You can see the very homogeneous opacity represent the consolidation at the right upper lobe. The margin of the consolidation is well defined because it is bounded by the oblique fissure, and the anterior margin is ill-defined, and there's a little bit of aerated lung at the anterior segment of the upper. So of course we cannot differentiate between this type of consolidation with mass, because consolidation also can represent mass, not necessarily pneumonia. So further investigation, further imaging is needed, like in this case, to differentiate between infection and pneumonia, infection of mass. Okay, so this is the same example, consolidation ill-defined margin which obscure the silhouette side, the silhouette of the right heart border and the right hemidiaphragm. In multifocal consolidation, this is an example of bronchopneumonia. You can see a poorly defined airspace nodule in the lungs. How about round pneumonia? The round pneumonia is a round area of consolidation. It can be caused by bacterial, viral, or septic emboli. Focal organizing pneumonia can represent as consolidation as well. Round atelectasis, and of course neoplasm like adenocarcinoma or lymphoma. This is an example of round pneumonia in right middle lobe. It's a round like mass-like consolidation, quite well defined at one border and ill-defined at the other margin in the right middle lobe. How do we know this is right middle lobe? Because part of it obscure the right heart border. But we still can see the right hemidiaphragmatic line. This is example of round consolidation which is caused by re-expansion pulmonary edema. This patient have pneumothorax on the right side, so the right lung is collapsed. when the pneumothorax is drained and the right lung is free expanded, there is fluid accumulation within the right lung, and that fluid accumulation can be focal, and on chest X-ray you can see as a round area of consolidation. So of course, when we want to give differential for this one, if you only have this X-ray, this opacity, there's a lot of more differential. But in this case, in this individual case, this is caused by re-expansion pulmonary edema. Similarly, pulmonary hemorrhage also can present as consolidation, can be multifocal, can be unifocal. And multifocal consolidation in this case is on the right upper and the left lower. It's unilateral. So probably patient can present with hemoptysis, but most of patients, there are some patients with pulmonary hemorrhage which doesn't present as hemoptysis. Diffuse consolidation, these are the differential. You can see with bilateral diffuse consolidation can be caused by edema, ARDS, diffuse pulmonary hemorrhage, and diffuse pneumonia. Diffuse pulmonary edema, I'm sure you're already familiar, is bilateral, symmetrical, and central consolidation with a bed-wing appearance. Bed-wing appearance represent the central consolidation in the hilar region there. Associated with cardiomegaly, if it is cardiogenic pulmonary edema, if it's not, so if the heart is not enlarged, so it is non-cardiogenic pulmonary edema. Sometimes we can see a septal thickening or curly B lines at the edge of the lungs. Septal thickening is not necessarily present in acute pulmonary edema. Is not present. Septal thickening is usually present in more chronic pulmonary edema. For example, in patient with chronic heart failure, you can appreciate the curly B line septal thickening, but in acute pulmonary edema, they may be absent of septal thickening. This is example of diffuse consolidation because of PCP, bilateral consolidation and ground glass opacity at perihilar distribution. So in this case, the heart is not enlarged. Basically, cannot tell the difference much, okay, between the consolidation of pneumonia and edema. That of course we need to find more salient features of PCP to differentiate between these two. ARDS, similar diffuse consolidation, both lungs, obscuration of the heart border, obscuration of the diaphragm, loss of silhouette sign. This is in clinical setting in patient with acute pulmonary distress with diffuse bilateral consolidation. So the radiological features are almost similar, but the pathology or the differential diagnosis are different. Okay. Next is atelectasis. So this is also important to recognize on chest X-ray. Atelectasis also present as opacity in the lungs, but we need to differentiate between atelectasis and consolidation. One, because mechanism is different. There are radiologic signs for you to identify atelectasis, and the pattern of atelectasis is also different. Depends on which lobe is collapsed. So mechanism of atelectasis can be because of obstructive atelectasis, passive atelectasis, compressive atelectasis, adhesive and cicatrization atelectasis, which is a scar. This is due to fibrosis. Okay, so atelectasis meaning volume loss or collapse of the lungs. This is example of obstructive atelectasis secondary to tumor. There is a bronchial tumor, endobronchial tumor in the left upper lobe. This is the atelectatic lung or collapsed lung in the left upper lobe. So on chest X-ray, this is an example of passive atelectasis due to pneumothorax. If you can appreciate this kind of atelectasis doesn't cause opacification on the chest or on the lung parenchyma. Okay, there's no increase in density in the lung. If you can imagine the atelectasis because of obstruction just now, there is opacification or increased density of the lungs parenchyma. So passive atelectasis is because of compression, external compression from the outside of the lung. In this case is pneumothorax. Sometimes pleural effusion also can cause a passive atelectasis. Okay. This is compressive atelectasis due to very large pleural effusion. This pleural effusion is very large. It causes mass effect to the lungs and causing collapse of the lung parenchyma. And even the mediastinum is shifted to the other side. So this is compressive atelectasis. It is not because of obstruction of the airway, it's because of the external compression. Adhesive and cicatrization of atelectasis. Adhesive atelectasis is when there's consolidation with scarring, especially this is in case of TB, tuberculosis, where there is a consolidation, infection, active inflammation together with fibrotic process during the infection. So adhesive atelectasis is because of volume loss, because of the consolidation. Okay. And when it progresses, when the acute inflammation has resolved and what left is only fibrosis, the lung volume is lost, is atelectatic, and is also associated with traction bronchiectasis. You can see airway, very prominent airway within the area of atelectasis. So this is what we call cicatrization atelectasis. Cicatrization atelectasis is because of scarring, volume loss due to scarring of the lung. Sign of atelectasis, direct sign. Atelectasis is volume loss. Direct sign, you can see displacement of the fissure or crowding of the vessels because of the volume loss. Indirect sign, you can see a local increased opacity or consolidation or associated with volume loss. Elevation of hemidiaphragm because of volume loss. Shifting of the mediastinum. Compensation or overinflation of the remaining lung or contralateral lung, and displacement of the high lung. So all these signs are signs of atelectasis. I hope you can appreciate is all due to volume loss. So the pattern, the pattern of atelectasis, it depends on which lobe is collapse. Okay, total collapse of the lung, total atelectasis, there will be white out of the one side of the lung, hemithorax. And then how do we know this is atelectasis or effusion? Because effusion will also give a similar appearance. We can see there is evidence of volume loss in the lung, the right lung. The trachea is deviated to the similar side of the opacification, meaning there is volume loss on the right side. In case of effusion, if this is a very large effusion is something voluminous, there's a fluid in the pleura, it should give mass effect to the mediastinal structures. So the trachea should shifted to the contralateral side of the heart. Mediastinum should be shifted to the contralateral side. But in this case, we can see there's a shifting of the structure, the mediastinal structure, to the ipsilateral side. So we know that this is volume loss. This is due to total collapse of the right lung. How about left upper lobe lung? We can see there's still aeration of bilateral lung fields, but there is the hilar. You can notice the hilar is slightly elevated, and there's a faint opacification in the right upper zone here compared to the left. On the left compared to the right. Okay, so this is caused by left upper lobe collapse. On the CT, you can see the collapse. The left upper lobe is collapsed, and what we see in the chest X-ray here, whatever is aerated is because of the left lobe aeration. In this case, on chest X-ray, we don't see opacification as well on CT because the compensatory hyperinflation of the left lower lobe compensates to the volume loss in the left upper lobe here. So that's why you can see only a faint opacification. Okay, so the clue for this left upper lobe collapse is elevation of the hilum. And if you notice, the left hemidiaphragm is also elevated. So there is evidence of volume loss in the left side of the lung. Right upper lobe collapse, different from left upper lobe collapse. This is the pattern. You can see homogeneous opacification in the left upper zone. This is the transverse fissure, which is elevated. Fine border between the consolidation and the aerated lung. So this is right total upper lobe collapse. In this case, if you can appreciate the golden S sign, there's this reverse S bounded by this fissure and towards the hilum. So there is mass, most likely there's mass in the hilum that caused the right upper lobe collapse. Okay, this is another right upper lobe collapse without golden S sign. As you can see, the fissure doesn't cause this inverted S sign. Okay, it's still right upper lobe collapse. But from this chest X-ray, we don't see the golden S sign, so we certainly we don't suspect mass here. Okay. Left lower lobe, left upper lobe collapse. Similar just now, tenting of the left hemidiaphragm, elevation of the hilum, Luftischel sign. You can see opacity in the left, faint opacity of veil-like opacity in the left lung, especially in the left upper zone, which obscure the left heart border or the left aortic border. This is a very faint opacification here in the right lower zone. You can see the right heart body is not is obscured. It's not very clearly visualized. Okay. The right hemidiaphragm is also a little bit elevated. The hilum is lower. Okay. The hilum is pulled down, slower from the normal. So we know that there is evidence of volume loss here. So this is caused by right middle lobe collapse. Okay, anything that obscure the right heart border is caused by right middle lobe pathology. Left lower lobe collapse. This is tricky if you don't scrutinize your hidden areas in your systematic review. You might miss the opacity behind the heart. So this is the left heart border. There's opacity, retrocardiac opacity, triangular shape opacity. The left hemidiaphragm is also obscured. The left hilum is pulled down. So there is evidence of volume loss in the left lower zone. left lung, lower lung. So this is caused by left lower lobe collapse. There's a triangular shape opacity behind the retrocardiac region. This is easier to detect. Right lower lobe collapse. There is opacification of the right lower zone, very well-defined margin, obscure the right hemidiaphragm. Can notice the right heart border is well seen, so you can still appreciate. So this is not a middle lobe pathology. When the right hemidiaphragm is obscured, so this is right lower lobe pathology. So this evidence of volume loss, you can see the hilum is pulled downwards. So this is a right lower lobe collapse. This is both, the two pathology coexist, right middle lobe and right lower lobe collapse. Right hemidiaphragm is obscured, right heart body is also obscured. Evidence of volume loss in the right lung. And this is last my last X-ray for this part of presentation.
Tadi Petronas ke?
There's a plate atelectasis in the left lower lobe here. There's not much volume
Tidak
loss.
Saliha. Well. Okay.
Sorry, can I ask Amir's iPhone to mute, please? Yeah, we'll go to the next presentation. Okay, so for the next 20 minutes, I will be showing cases regarding chest X-ray in emergency. Is that probably we could make this like a two ways communication. Probably some of you can give your opinion on the cases that we're discussing. Okay. So for this chest X-ray interpretation, this is the basic that we normally do. When reviewing chest X-ray, patient identification, we decide whether it is AP or PA projection, sitting or erect X-ray, or supine X-ray, penetration and rotation. So before we even start looking at the pathology, we already identify the chest X-ray. Patient identification is very important. We don't want to treat the wrong patient with the wrong reason. And then secondly, lines. This is very important as well to review before we even go to the airway and mediastinum and the lungs. Check the lines, whether they are in the correct position or there is malposition of the tubes. After that, only we go to the systematic review of the chest X-ray. I'm sure you're all familiar with the systematic review. Probably you already have your own system on reviewing chest X-ray. Airway, mediastinum, check for the heart, and the lung parenchyma, pleura, bone, and soft tissue. So by doing this systematic review, we're less likely to miss findings in the chest X-ray. And then finally, we can come to diagnosis. And don't forget about hidden areas. Hidden areas is the most area that is most likely forgotten when we're reviewing chest X-ray. The lung epicyst, it's very important to review, specifically review lung epicyst, look for masses and pneumothorax. Behind the heart, retrocardiac, look for consolidation, mass, or hiatus hernia. Below the diaphragm, you can look for free gas, pneumoperitoneum, lines and tube. Nasogastric tube should be behind the left hemidiaphragm. Gastric distension or any bowel obstruction. Bones and soft tissue, we don't miss any fractures, any masses, evidence of mastectomy that can give us clue to what's the underlying abnormality in this patient, in the particular patient. Emphysema, evidence of previous surgery, and don't forget about the hilum. Look for mass, lymphadenopathy, or any vessel enlargement that can give you some clue on what's happening to the patient. Okay, now let's go to case 1. This is 80-year-old female with MVA. It's very unfortunate. So in this case, if we run by our systematic review of the patient identification check, penetration, this is acceptable. You can see the vertebra behind the heart. Inspiration, of course, we cannot ask the patient to inspire. This is a MVA case. About the line check, the ET tube is very well at the carina. I think it's a little bit lower, should be a little bit higher at T4 level. Okay, there's a bilateral chest tube insertion. There's evidence of emphysema. When we see emphysema, we need to determine whether there's a multiple refractures. There are multiple refractures on the right side of this patient. So the line, the ECG lines, tube, lines also can obscure. So can obscure part of the X-rays. So determination of the lines and tube position is very important. Okay, in case 2, anyone can shout what is the abnormality that we can see from this chest X-ray. Okay. Anyone can answer or just give opinion to what's the problem or what's the abnormality on the chest X-ray. I can see a few people in the auditorium. Is there any doctors, MOs, or housemen? Anyone just can shout out the abnormality of the chest X-ray. We already reviewed about collapse and consolidation just now.
It's passive pleural effusion on the left side.
Okay, you see opacification on the left side. So you think it's massive pleural effusion. Okay. And what else do you see?
Yeah, there's a displacement of the trachea to the right side.
Okay. Yeah, very good. Have you done your line check, your tubes check?
To the right.
Sorry, the ET tube?
Right.
To the right. Yeah. Yes. Where do you think the ET tube is located? There's a trachea, there's a carina.
It goes to the right side.
The right, the trachea divides into right and left.
Right.
Okay. Yes. So the ET tube is to the right. located in the right main bronchus. So this is bronchial intubation, right bronchial intubation, causing deaf lung collapse. Very good. May I know what's your name? What's the doctor's name?
My name is Lena.
Diana.
Liana.
Liana. Okay.
Liana.
Very good. Liana. So this is the importance of tube check or line check. So the intubation, the ET tube is actually located at the right main bronchus, resulting in collapse or pacification of the left hemithorax. I cannot argue with you. There is left pleural effusion. I probably will agree with you because of the trachea shifted to the contralateral side. So there is some evidence of volume expansion on the left hemidiaphragm. Left lung. Okay, very good. Next case, 70-year-old male, history of head and neck cancer. Yeah, so this is the chest X-ray. Can I have next person to give opinion on the chest X-ray? What do you guys think? What's your name, doctor?
My name is Annabelle.
Annabelle. Okay. So what do you think about the chest X-ray?
Is there a consolidation at the left lower zone?
Okay, we think there's consolidation there. Have you done all your line checks before you go to the other systematic review? Have you checked the lines?
Obscuration of the cardiophrenic border. The right cardiophrenic border is obscured. Cardiophrenic border.
Yeah, this is a cardiophrenic border. How about this line? What do you think this line is? Yes, it's NG tube. Do you think the NG tube is at the correct position? Where should tip of NG tube located?
Over the stomach, over the left gastric.
Yes, it should be, the tip should be located here, right, at the left hemidiaphragm and at the gastric region. But in this case, it's located rather to the right. So where do you think this NG tube located? It goes to the right. Yes, very good. So this is NG tube passed down to the right main bronchus. So that's a trachea goes to the right main bronchus, and then probably goes to the anterior segment of the lower lobe bronchus. So this actually our lungs is the margin of the lungs is way below the diaphragm. Okay, this is because the anterior sulcus of the lung. So anterior sulcus of the lungs. So there is part of the lung that is anterior to the hemidiaphragm. What we see here, the dome is at the middle of the base of the lung. The dome of this line represents the dome of the diaphragm. So that's why we can still see the tube beyond the diaphragm. This is not tube going into the peritoneum. This is still in the lungs, but it is at the anterior sulcus of the lung.
Dr. Siti,
Yes.
may I ask how old is this patient?
70.
any history of COAD or smoker? Because it's almost impossible to go through the vocal cord, right?
The head and neck. Patient had head and neck cancer. So probably the vocal cord is maybe they intubate beyond the vocal cord. I'm not sure about the COPD history. So the point for the learning point.
Who inserted the rice to staff? Who inserted the rice to?
So just the learning point from this X-ray is line check. It's very important before we even go to the lungs parenchyma or the heart or the pleura. Line check is very important. The one that opacity that you see consolidation, this at the left lower zone just now, this I think is the pericardiac fat, pericardial fat, because it doesn't obscure the heart border, and it's quite loosened. It's not consolidation. So sometimes we can see pericardial fat line, which is slightly opaque from the lung. Okay, very good. Next case, young patient with chest pain. 20-year-old patient with chest pain. So anyone wants to try about the chest X-ray? So this time there's no line, so don't need to do a line check. And we can go straight to your systematic review, not forgetting the hidden areas. Next, anyone wants to try or just shout the answer? We just can discuss. Systematic review. What do we think about the airway? Is the airway central? Is it normal position? Is it slightly shifted to the left? You guys agree it's slightly shifted to the left?
Yes.
Okay. Yes. Okay. So then we already checked the airway. So the airway is slightly shifted to the left. Then next, the mediastinum, the heart, the cardiac. Is it in normal position, or do you think it's enlarged, or is it shifted to the right or to the left?
Every patient has scoliosis.
Ada sikit on the mild right scoliosis, but the heart, if mild scoliosis, sometimes the heart is still in, mediastinum is still in the middle. But this one, we don't see the right heart border. Can see the left heart border very well, but the right heart border is obscured, or we don't see it. So with shifting of the airway to the left, and the right heart border is shifted also to the left. Okay, so now are we thinking about are we dealing about some kind of volume loss on the left side? Okay. Yes, okay, very good. So now we need to find what caused the volume loss. Do you see this opacity at behind? Yes, very good. This the opacity at the behind the heart, retrocardiac opacity, triangular shape opacity. The hemidiaphragm is also obscured. At the region of opacity is obscured, the hemidiaphragm lining. So there is evidence of left lower lobe collapse. Okay, then we go to the lung parenchyma. The aerated lung parenchyma is okay. So the lung parenchyma that is opacified is at the retrocardiac region. So this is a hidden area that very important in our systematic review to check the hidden area. Do you guys notice this loosened ring in the hilar region? What this could be? This is not normal. It shouldn't be there. So in this region, you don't see the aortic knuckle, right? You don't see the lines of aortic knuckle. So this lucency is caused by air in the mediastinum that circling around the aortic arch. So this is pneumomediastinum. So this patient has pneumomediastinum with left lower lobe collapse, left lower lobe atelectasis.
What do they suspect is the cause? TB.
This patient, young patient with chest pain, this patient has underlying asthma.
Oh.
So asthma cough can cause a spontaneous pneumomediastinum. Yeah. But the collapse lung, of course, there are more differential diagnoses that we need to investigate, like mucus plugging or something else compressing externally or endobronchial compression that cause a collapse. But detection of lung collapse in this case is important because this is the pathology. Okay, and then we finish off the systematic review. The contralateral lung parenchyma, the vessels is not enlarged. Pleura, there's no pneumothorax, no pleural effusion, bones and soft tissue. Okay, and don't forget about the under diaphragm. So this is air under diaphragm on the left side is because of the gastric air bubble, not because of pneumoperitoneum. Okay. So hidden area, epiphysis, hilar, retrocardiac, and under the diaphragm. That's our systematic review check. I have another 1 minute. Maybe I can show you my last case. Case 5, 70-year-old male with shortness of breath. I think this is quite obvious. Opacity, everyone can see triangular shape opacity at the right lower zone there. This is the right lower lobe collapse. Why we see this collapse? Because there's evidence of volume loss. The trachea is shifted, so it's shifted to the right, and we cannot see the this triangular shape opacity behind the heart. Okay, that obscure this part of the right hemidiaphragm. So this is complete right lower lobe collapse with obliteration of the silhouette of the right hemidiaphragm, and shift. The mediastinum is also shifted together with the trachea. The mediastinum is also shifted slightly to the right. And elevation of the hemidiaphragm. So this is complete right lower lobe collapse. So this is the outline. This is the outline of the lungs, the collapsed lung on the left lower lobe, right lower lobe, and that is the right hemidiaphragmatic line, which is obscured by the collapse. This is another collapse. This is right upper lobe collapse. This is the one that I show you, the golden S sign, the inverted S. We can draw it as like that. So when we see right upper lobe collapse with golden S sign, we need to suspect right hilar mass. Okay, this is right upper lobe collapse caused by right hilar mass, resulting the total collapse of the right upper lobe. It's already 9.
Boleh sikit kot.
Boleh sikit lagi.
Boleh.
Okay.
No problem.
Okay. You can show 1 or 2. Case 6, sudden onset of epigastric pain. Okay, this is tricky. If we don't do our systematic review, aortic, there's the trachea is slightly deviated to the right, but you see the mediastinum is enlarged. Yeah, there's widening of the mediastinum, right? Trachea is deviated to the right, so there must be some mass effect that caused the trachea. That we don't see volume loss here. Okay, so there is not collapse. The shift of the trachea is not because of collapse of the right side, but rather something pushing from the left side. Then we look at the particular area here. Mediastinum is widened, and there's calcification of the aortic arch here is displaced away from the aortic silhouette. Okay, so that is aortic silhouette. That is a calcification of the aortic arch. So this indicates an lifting of the intimal calcification. The heart contour is enlarged. There's a splaying of the carina that indicates arterial, left arterial enlargement. The left atrium is located here. Okay, the lung details has been obscured by the heavy shadowing of the chest radiograph, heavy windowing. So the lung parenchyma is not optimum for us to comment. There's no airspace opacity. We can see there's a small left pleural effusion is present. Okay, so correlating with our findings, there is some mass effect at the left upper mediastinum that cause shifting of the trachea to the right, and calcification and displacement of the intimal calcification of the aortic arch, widening of mediastinum, left pleural effusion, patient with chest pain, shortness of breath, severe epigastric pain. So we should be thinking of in line of an aortic dissection pathology from the mediastinal structure or mediastinal vascular structure. So on CT, this is what we can see. The lifting of the intimal calcification is because of the dissection. This is aortic arch. So the calcification there, this intimal calcification is shifted endovascular inside the vessel. It should be at the wall of the vessel here. So we can, on X-ray we should be at the line of the aortic arch, but in this case it's inside the shadow of the vessel. So it is caused by dissection, aortic dissection. So this is a Stanford type A dissection, thoracic aortic dissection, involving the ascending aorta, aortic arch, and also descending thoracic aorta. Okay. Case 7, 55-year-old male, progressive shortness of breath over the past weeks. There's a very large homogeneous opacity in the left hemidiaphragm, in the left hemithorax. Homogeneous opacity, fusion, collapse, or consolidation. But to differentiate between these three, we see this opacity is associated with meniscus sign at the superolateral aspect, which indicates a fluid in the pleural space. So this opacity is caused by pleural effusion. We can see there's mass effect onto the airway. Airway is shifted, so this is volume. It's not volume loss, it's volume expansion in the pleural space here that cause the shifting of the trachea and the mediastinum to the contralateral side. Okay. So this is caused by massive left side pleural effusion. Case number 8, 18-year-old male. Is it pneumothorax or not? So what do you think? Is this a pneumothorax or not pneumothorax? Get enlarged a little bit.
Yeah, like pneumonia.
Yes. Then you can see the streaky lines lucency at the superior mediastinum, right? Here, with air tracking down the mediastinal border bilaterally. You can see that's air. And this is on the left side. So this is consistent with pneumomediastinum. Okay. The anterior junctional line is also outlined by air. Okay. Anterior junctional line would be this one. Okay, there is no extension to the neck, and this patient has an azygous fissure which is outlined by air. So there is presence of a mild right apical pneumothorax. Can see? This is azygous fissure which is outlined very well by the air. This is this is pleural air, pneumothorax, and that's air inside the lung. Okay. So cardiac size is normal, lung and pleural spaces clear. There's no pleural effusion, so there's no subdiaphragmatic gas as well. So this patient has apical pneumothorax and also pneumomediastinum. So differential include asthma in young case, or alternatively an esophageal or tracheal perforation, or spontaneous esophageal rupture, or the causes of pneumomediastinum. So this could be further characterized with CT thorax. Okay, next 9. I think this is my last case. 70-year-old male, diffuse abdominal pain. This is quite obvious. Anyone can shout out the diagnosis. You can see it from the back of the room, I think.
Okay, gas under the diaphragm.
Yes, very good. It's gas under the diaphragm. It's very obvious on the right side. You can easily detect it on the right side because we have our liver in the right side. That line represents our right hemidiaphragm. Gas below that hemidiaphragm is pneumoperitoneum. Gas above the diaphragm is air inside the lung. Okay. On the left side, it's quite tricky because left side we have our stomach, gas in the stomach, gas in the bowel. If you notice, this is the line of the stomach. So this is gas inside the stomach or bowel, but there's also gas outside the line without the arrow. So this gas is a free gas, free pneumoperitoneal gas. That gas is gas inside the stomach. Okay. So on the left side, it's quite tricky to look for pneumoperitoneum on the left side because of gas in the stomach. It's always easier to look on the right side. But if you see gas on the left side, just be careful and scrutinize further whether there's gas outside and inside the border of the bowel wall. That indicates, that could give you a clue to the presence of pneumoperitoneum. This is what we call a Wriggler sign, where the presence of gas inside and outside viscous, outside the bowel. Okay. Okay. So my take-home message is just remember the hidden areas, lung abscess, for pneumothorax or masses such as pancreas tumor. Behind the heart, look for consolidation, mass or hiatus hernia. Below the diaphragm, especially free gas, lines and tubes is very important. Gastric distension, bowel obstruction, and don't forget about bones and soft tissue. Trauma case especially, look for fractures. Follow lines of every bones, every ribs, so that you can do not miss fractures. Masses, mastectomy, which can give us some clue to the patient's conditions, subcutaneous emphysema, or any previous evidence of previous surgery. And don't forget the pulmonary hilum, look for mass, lymphadenopathy, or vessel enlargement. Okay, I think that's my last slide. Thank you very much for
Can you please
listening.
go back like 3 slides? The pneumomediastinum. Okay. Pneumomediastinum.
Pneumomediastinum, sorry. This
See, just how would you, I can, when we appreciate the cardiac shadow, you can see the distinct outline of the vertebra, right? So how would you, see?
okay.
You see that. So that's one of the indicator of pneumomediastinum. How would you describe that if we were to communicate? Then, see?
Okay.
You can see the vertebra. How would you describe that in a radiology report?
This is anterior junctional line.
Ah.
And anterior junctional line is caused actually in pneumomediastinum we do this is the visualization of anterior junctional line is not specific for pneumomediastinum. Sometimes anterior junctional line is caused by pleural interface at the anterior lungs, right and left lung, at the very anterior part of the lung. Right and left lung is only divided by their pleural. So that makes an anterior junctional line. It can be some patient, normal patient, we can see the anterior junctional line if the lungs interface. If you can see the lung interface there. Some patient we don't see it, but for pneumomediastinum it's not specific. But in this case we can see. The more specific sign for pneumomediastinum is the outline, loosened outline along the cardiac border. Sometimes you can see the pericardial line in between the heart and the lungs. Okay, and this one lines like this. This is the mediastinal line. This is air inside the mediastinum, and lines that outlines the vessels in the mediastinum. So this line here that outline, this is aortic arch, aortic knuckle, aortic arch punya line. So that air outlines the aortic arch, and this air also outlines the pulmonary vessels adjacent to the aortic arch. And then we can see air outlining the trachea. This is the right paratracheal stripe. This is left paratracheal stripe, and that's air outlining the trachea. So all these lines is not supposed to be there. Okay.
Okay. You comment on the apical pneumothorax. Just now you said on the right. You see the left as well. That one. Yeah.
Do you see the left?
Is that I
okay.
I can easily miss this chest X-ray the pneumothorax. I just want to get your pearl of wisdom how to not to miss it.
Okay. Pneumothorax is when you can see air and when you can see pleural line.
The one that is the pleural line, there's a lucency. On the left side is a little bit somewhat like that as well.
Okay. In this patient, we established this is a pneumomediastinum. So if we don't see the pleural line on the left side, so we don't call it as pneumothorax. Small pneumothorax. Sorry?
The most important is the pleural lining. If you don't
Yes.
get just a mere lucency, it may not be
Yes.
enough. But here, a clear line of pleura that,
Yes.
yeah, that
Yes.
one is the key.
Yeah, exactly. If you see the if you want to look for pneumothorax, look for the pleural line. This pleural line give you very strong clue.
The shape is very round, unlike the classic pneumothorax, which is very linear,
Yes.
all the way to the pleural line.
This patient ada azygous fissure. This is normal normal variant. I think that's why that makes the round shape pneumothorax.
Oh.
That is the
So not
azygous lobe.
everybody has that azygous.
No.
Yeah lah.
Not everybody.
Okay.
Yeah, true. Not everybody have this azygous lobe or azygous fissure.
Cik, X-ray ni saya tak nampak apa-apa cik. Tapi saya bukan pakai X-ray. Jangan bimbang cik macam mana keadaan okey. Apa kita akan buat? Kita akan hantar X-ray dari jawatan kecemasan ni ke jawatan X-ray. Nanti dia akan buat laporan rasmi lah. Cik boleh balik dulu, saya bagi MC.
Oh my God.
Nanti akan ada, kita panggil pakai komputer kan, pakai smartphone. Kita punya EM watch kan, nanti kita akan beritahu. Besok cik besok kan. That's what we do. Pakai X-ray ni, gambar dia tak berapa jelas. Yang paling bagus, CAT scan, CT scan. Tapi kita hospital kerajaan jarang-jarang buat macam ni. Dia bila betul-betul urgent kan, betul aku bawa kita buat. And that's how you counsel the patient kan. Apa ada kemungkinan bocor paru-paru sikit yang kita tak nampak. X-ray tak nampak, betul. Tapi ada kemungkinan cik balik ni tiba-tiba cik rasa sesak nafas kan. Panggil ambulans. Boleh masih boleh jadi macam tu. Jangan nanti kita punya EM watch appointment by online kan. Jangan bisnes. And that's how we say. That's how we say. So if the patient goes suddenly funds money go to hospital swasta kan. Hospital swasta buat CT scan. And they find anything, we already told him so. Betul tak? See? What? Please and during office hours we have the radiology hot seat and please I tengok X-ray macam ni pun I seram. Kalau if you are a junior MO you will miss it. You say nothing wrong and send the patient off. If you are a junior MO. But then again, do not treat the X-ray, treat the patient. Assess holistically. Betul kan? Something's wrong. Saya asma memang asma, tapi lain macam lah asma ni. Saya tidur tak sedap, mengah kan, sakit. Something's wrong.
Doctor, patient ni patient asma ya. It's not trauma right?
Asma kan? Asma.
Ini patient asma.
Jadi all that changes, pneumothorax, mediastinum, are caused by asthma.
Patient cough, asthma, SOB, cough, like straining. Patient constricted, maybe patient try to breathe very hard, and somehow the air tend to leak. And leak in the mediastinum.
A little bit of pneumothorax yang tak nampak. Kalau buat CT scan nampak. Okay. Dekat hospital swasta. Alright. Okay. Ada apa soalan? Sini nampaknya tak ada. Dekat WhatsApp pun tak ada. Kalau kita boleh jemput Dr. Rohani ada apa-apa pemakluman lagi. We thank you very much for participating with us.